Welcome. Today we delve into a rare and devastating neurological disorder, Alexander disease. This condition primarily affects the brain's white matter and is often fatal, particularly in its most severe forms. Join us as we explore the intricacies of Alexander disease, from its causes to potential treatments. Alexander disease is primarily caused by mutations in the GFAP gene, which stands for glial fibrillary acidic protein. This gene provides the instructions for making a protein of the same name, GFAP. GFAP is a major component of intermediate filaments found in astrocytes, a type of glial cell in the brain. These cells support and protect neurons. Mutations in the GFAP gene lead to the production of abnormal GFAP proteins that clump together, forming what are called Rosenthal fibers. These fibers disrupt the normal function of astrocytes and ultimately lead to the symptoms of Alexander disease. While the majority of cases are caused by spontaneous, new mutations, some rare instances of familial inheritance have been observed, where the mutated gene is passed down from parent to child. The pathophysiology of Alexander disease centers around the accumulation of Rosenthal fibers within astrocytes. These abnormal protein aggregates disrupt the normal functioning of these crucial support cells. Astrocytes play a vital role in maintaining the brain's microenvironment, regulating blood flow, providing nutrients to neurons, and removing waste products. The presence of Rosenthal fibers interferes with these processes, leading to white matter damage, a process called demyelination. This damage disrupts the communication between different brain regions, causing a variety of neurological symptoms. The severity of the disease often correlates with the extent of Rosenthal fiber accumulation and the degree of white matter involvement. Alexander disease is exceptionally rare. Its exact prevalence is difficult to determine, but estimates suggest that it affects fewer than 1 in a million people worldwide. It affects people of all races and ethnicities equally. Both males and females are also affected in roughly equal numbers. Because it is primarily caused by spontaneous mutations, there are no known environmental or lifestyle factors that increase the risk of developing Alexander disease. While exceedingly rare, it is critical to understand the disease's presentation and diagnosis to improve outcomes for those affected. The signs and symptoms of Alexander disease vary depending on the age of onset and the specific type of the disease. In the infantile form, which is the most common and severe, symptoms typically appear before the age of 2. These can include developmental delays, seizures, an abnormally large head size or macrocephaly, stiffness in the limbs, and intellectual disability. In the juvenile form, which presents later in childhood, symptoms can include difficulty with coordination, speech problems, swallowing difficulties, and seizures. The adult form is the rarest and most variable, with symptoms that may include muscle weakness, spasticity, and difficulty with movement. Some adults may also experience psychiatric disturbances. The variability in symptom presentation often makes diagnosis challenging. Diagnosis of Alexander disease typically involves a combination of clinical evaluation, neuroimaging, and genetic testing. A thorough neurological examination is performed to assess the patient's symptoms and neurological function. MRI of the brain is a crucial diagnostic tool, often revealing characteristic features such as white matter abnormalities, particularly in the frontal lobes, and the presence of swelling or lesions. Definitive diagnosis is usually confirmed by genetic testing, which identifies the presence of mutations in the GFAP gene. In some cases, a brain biopsy may be performed to examine the brain tissue under a microscope and identify the presence of Rosenthal fibers. However, genetic testing is generally preferred as it is less invasive. While Alexander disease is often categorized by age of onset, primarily infantile, juvenile, and adult forms, some experts also classify it based on the specific mutation in the GFAP gene. Certain mutations tend to be associated with more severe presentations, while others are linked to milder forms of the disease. Furthermore, the clinical presentation itself can be categorized into subtypes reflecting the predominant neurological deficits seen. The infantile form is frequently associated with severe motor and cognitive impairment, while the juvenile and adult forms may present with ataxia, bulbar dysfunction affecting speech and swallowing, or even primarily psychiatric symptoms. This heterogeneity underscores the complexities in understanding and managing Alexander disease. Currently, there is no cure for Alexander disease, and treatment focuses on managing the symptoms and providing supportive care. Seizures can be controlled with anti-epileptic medications. Physical and occupational therapy can help improve muscle strength, coordination, and mobility. Speech therapy can address speech and swallowing difficulties. Nutritional support may be necessary to ensure adequate nutrition, especially in individuals with swallowing problems. In some cases, surgical interventions may be required to address hydrocephalus, a buildup of fluid in the brain. Genetic counseling is recommended for families affected by Alexander disease to understand the risk of recurrence in future pregnancies. The goal of treatment is to improve the patient's quality of life and provide comfort to both the patient and their family. Because Alexander disease is primarily caused by spontaneous, new mutations in the GFAP gene, there is no known way to prevent it. In rare cases where the disease is inherited, genetic counseling and prenatal testing may be options for families who are concerned about the risk of having a child with Alexander disease. However, given the rarity of inherited cases, prevention strategies are limited. The prognosis for individuals with Alexander disease varies depending on the type and severity of the disease. The infantile form typically has the poorest prognosis, with most affected individuals not surviving beyond early childhood. The juvenile and adult forms tend to have a more variable course, with some individuals living for many years with the disease. Recent research efforts are focused on developing new therapies for Alexander disease, including gene therapy approaches aimed at correcting the GFAP gene mutation. Other research focuses on developing drugs that can reduce the formation of rosental fibers or promote the clearance of these aggregates from the brain. While these therapies are still in the early stages of development, they offer hope for improving the prognosis for individuals with Alexander disease in the future.